Welcome to the WMed Specialty Spotlight Podcast, your virtual mentor for choosing a medical specialty and planning a career in medicine. On this podcast, we probe practicing physicians with questions about their specialty, the decision algorithm that helped them determine that the specialty was right for them, and then for advice about long-term career planning, irrespective of the field they went into. I'm your host, Dr. Biren Shah, WMed Assistant Dean for Career Development. Before introducing today's guest, I just wanted to remind you that selected show notes for this episode and all episodes can be found on our website at wmed.edu/specialty spotlight. The specialty of today's show is radiation oncology, and the physician here to tell us about it is Dr. Simon Brown. Dr. Simon Brown is a board-certified radiation oncologist who joined West Michigan Cancer Center in July 2022. Dr. Brown came to Kalamazoo from Springfield, Illinois, where he served for 3 years as a radiation oncologist and assistant professor at Southern Illinois University. Dr. Brown received a Baccalaureate of Arts in Human Biology from Brown University in Providence, Rhode Island, where he played running back on the Brown football team and bass trombone for the jazz band. He followed up his undergraduate education with a medical school degree from the Medical University of South Carolina in Charleston. While there, Dr. Brown managed a nonprofit clinic providing care to the indigent and served as a physician recruiter. He also published articles on health disparities. Dr. Brown then headed across the country to Portland, Oregon, where he completed a surgical internship and radiation oncology residency at Oregon Health and Science University. During his residency, Dr. Brown served as a physician liaison, clinical instructor, and chief resident. He also researched and wrote chapters on radiation treatment for benign disease, which are published in seminal textbooks for radiation oncology. In 2017, Dr. Brown was selected as a clinical research fellow in conjunction with the European Society of Radiation Oncology and the American Association for Cancer Research held in the Netherlands. Along with his board certification in radiation oncology, Dr. Brown is certified by the American Board of Medical Quality and is an active member of the American College of Radiation Oncology. He has developed and written multiple clinical trials as well as written editorials in JAMA Oncology. His clinical teaching and research interests includes medical education, mentorship, health disparities, and cancer treatment outcomes for solid tumor malignancies. So without further ado, Dr. Simon Brown. Dr. Brown, welcome to the show.
Thank you. Thank you for having me. Happy to be here.
Well, first of all, thank you for taking the time to talk to me. So you heard me read your bio. Is there anything you would like to add and at the very least share a little bit about yourself and your decision to go to medical school?
The music, I played bass trombone and then also tuba, and in the
Okay.
band. And I'm still a low brass enthusiast today. So I try to get some time to do that. I'm glad you highlighted that. I appreciate that. My decision to go to medical school kind of stemmed from, my upbringing, from my parents. My mother's a elementary school teacher. My dad's a United Methodist minister. So community was very important to them. And education and learning was very important to my mom. So medical school seemed like the perfect route to always strive for continuous learning while also being able to provide for the community. And so around my sophomore year, before my junior year, I made the big decision to actually stop playing football and go and switch to pre-med. That was like one of the biggest decisions I've made, like of my young, adult life. And but I haven't regretted it since. And yeah, now, been practicing for 5 years. I mean, there's a lot of stuff in between all that, but we can go into that. But yeah, that's kind of how it all started.
And the way I like to start off is by reading you a description of your specialty from the Careers in Medicine website. which is hosted by the Association of American Medical Colleges. And then I'll ask you what you think. And so here it goes. Radiation oncology. A radiation oncologist uses ionizing radiation and other modalities to treat malignant and some benign diseases. Radiation oncologists may also use computed tomography, scans, magnetic resonance imaging, ultrasound, and hyperthermia as additional interventions to aid in treatment planning and delivery. How much do you agree with that? What would you add or subtract to ensure that anyone listening was well informed on the practice of radiation oncology?
Sure. I think that's a good broad description. I think what they're trying to get at is that, we use targeted methods like diagnostic imaging with MRIs and CT guidance to deliver precise treatment towards a target within a person's body, and could that be for cancer? It could be for even benign diseases, like something akin to like a Dupuytren's or keloid or arthritis. We're able to use the diagnostic images that we have to help guide our treatment fields and to guide treatments towards, where a certain problem could be on a person.
Can you take us through what a daily or maybe weekly routine looks like for you, followed by
Sure.
a typical series of patients that you'd see, and what are the typical outcomes for these patients?
Yeah, so there's a lot of variability within my field. A lot of it stems for if you're going to be in the community or if you're going to be primary in the academic setting. But for my particular day, here I am in the community here in Kalamazoo. Like my typical day starts from, somewhere between 7 and 8 a.m. And then when I get in, I review the prior treatments from the days past to make sure all the patients that receive treatment lined up appropriately with those diagnostic images that I told you about. And then I prepare for the consults of the day. It depends on if it's a consult day, a follow-up day, or an on-treatment visit day. But typically we see about 4 to 6 consults. I do. If it's a consult day, if it's a follow-up day, somewhere around 12 to 16 follow-ups. And then the patients who are actively receiving treatment, we see patients once a week to kind of manage the side effects and to kind of give them expected management of what to come while they're receiving radiation treatment. And so depending on how many patients you have on treatment, I think, on an average practitioner, roughly around 18 to 20, but if you're really busy, you can get to 30 to 40 patients on treatment. And you would see all those patients in one day, spend about, 5 to 10 minutes maybe with each one of them, kind of going through those side effects. And then at the end of the day, usually around 4:30, 5 o'clock, you're again reviewing the patients that receive treatment, making sure everything lined up perfectly, and then you're reviewing plans for patients that for the consults you just saw, or new treatment plans that you're about to do. So it varies. If you have time as an academic doc or even in the community for a day to do like planning where you don't see patients, it's really nice because then you can take time out to do extracurricular activities like mentorship, do this particular podcast that I have, right? I have blocked time to pursue those opportunities, right? It may be half a day, it may be a full day, but you're able to kind of catch up throughout the week to make sure you stay on task.
And how does the practice of radiation oncology change depending on whether you're private versus that of a public institution, government, urban versus rural? And is really radiation oncology more outpatient rather than inpatient?
Yeah, it's definitely mainly outpatient. Most, community practices, we do not have an inpatient service. If someone, requires an inpatient consultation, we will go to the hospital to see them, but we don't carry an inpatient service. Some academic centers are now starting to have palliative care services where they do have inpatient services, but that is definitely in the minority. To answer your question about the differences in practices, each practice is different, like in the community, in academics. And what do I mean by different? So when you're in the community, like your main focus is really you're a clinician, you're treating patients. And, like the priority isn't on publishing papers. You can still do that if you have time or want to, but that's not like how you're gauged, like in academics, you have, tiers. I remember applying to certain academic programs when I was coming out of residency, and things that you would be graded on for like for promotion from assistant professor to associate professor was in addition to your clinical service load, but also with conferences, how many presentations you did at conferences, how many papers are you publishing, like the publication that you're writing in. Radiation oncology is a very very, I think, in general, academic field, such that like you really, for every patient that you see, there is a study, or there is a rationale for why we do what we're doing. And the only way we get to that is because there are folks in our field that primarily focus on that. We're constantly pushing the needle. We're constantly pushing and improving. And so there are folks that help do those clinical trials so that folks like me in the community can give cutting edge therapy to everyone. You don't have to travel to a big center. It's the big centers that are putting out that research so that we can execute it on the community level.
And as a radiation oncologist, are you treating all types of cancers, or are you subspecialized? Are there kind of the subspecialization within radiation oncology so that you're an expert in certain particular types of cancers?
Again, it varies. When you go through residency for radiation oncology specialty, radiation oncology is the only field where you get 4 years dedicated training to treat all solid tumors, right? So when you come out of radiation oncology residency, once you pass your oral boards, you are a solid tumor expert, okay? You are the expert, and so, what you decide to do after that depends on what job you choose, right? So in the academic world, typically you do a certain sites. Maybe you'll be thoracic and head and neck, or maybe you'll be GI and GU. In the community, depending on how many resources you have, how many practitioners, how many partners you have in your group, will determine whether or not you're able to subspecialize. Most community practitioners, we treat a little bit of everything. Like me personally, I like to specialize in GI, GU, thoracic malignancies, but every so often I see a head and neck cancer patient, every so often I see the rare breast cancer patient, or a CNS malignancy, like we're all trained to do that, and it depends on just the practice setting you're in that determines whether or not, So if you want to specialize, you can, but if you want to be in the community and just kind of be more of a general practitioner, that's also a route you can take.
As a radiologist, I get medical students that think of radiology not having much patient-facing interaction. And within radiology, there's a wide spectrum in terms of degree of patient-facing interaction. What would you say for radiation oncology? Typically, how much patient interaction do you have?
It is a lot, and it is amazing. I think it's probably one of the most rewarding experiences that I have as a physician. When a person gets a cancer diagnosis, it's scary, and usually you see patients when they come in, they're coming with their loved ones, their daughters, their sons, their brothers or sisters. I mean, I've had a room one time where there was 9 family members, right? And so, you're explaining to them, in a way that they get an understanding of their cancer diagnosis and their treatment options. And once, the decision is made where radiation is indicated, radiation regimens, radiation treatments, they can go from, 2 weeks to 5 to even 7 weeks, for certain malignancies. And, during that time, you're seeing these patients once a week. You're seeing their family members, with them once a week. And so you build this rapport with the family members. And before you know it, I mean, like, they become your family, right? And so, like the interactions you get with patients, I would say is very robust in radiation oncology. You're interacting with patients at a very vulnerable time. So the impact is that much greater. And so, very rewarding, and probably one of the things I really enjoy about my field.
Another concern for students in the fields of like radiology and radiation oncology is that of radiation exposure. Can you comment about that in terms of that kind of myth in terms of concern of radiation exposure in these special?
Yeah. No, the radiation exposure is very mitigated. I mean, you see me right here. I have like a badge right here with a dosimeter on, and every quarter it gets measured to make sure that we stay within a certain limit. But it's clinically negligible, honestly. The treatment machines that we deliver radiation from or behind vaults. The patients, when they get treatment, they're not radioactive. They're radiated, but they're not radioactive. So there's not like there's not a risk there when you're interacting with a patient who just gets finished with radiation. Now, when you're using, local sources like, brachytherapy, care must be maintained when using local sources. But again, there are safety procedures in place to, again, minimize the radiation exposure, a LARA, right? As low as reasonably achievable, and so we practice those principles. And again, and you're monitored all the time, and so very low risk. I have no concerns, there. I mean, we have, our field is growing, like with regards to, diversity, women, even some of the physicians, that are expecting, like we're still radiation oncologists, right? It's just, there's clinically insignificant exposure risk, because of the precautions that we do.
What do you think is the most exciting thing that's occurring in your specialty? And conversely, what would you consider the most mundane about your specialty?
One thing I really, drew me to the field is that, like, how we do things today may not be how we do things, a year from now. We're constantly improving our technology. We're becoming more precise with our treatments. The tools that we use to measure dose, they're just getting fancier. How we, contour and identify tumors in patients are improving. And so it's a rapidly changing field where you have to stay on top of your game. It's just, you don't learn something and then kind of sit and just keep practicing within that same wheelhouse, right? There's always something new. There's always new data. We're always, sharpening that sword. And I think radiation oncologists, we do that a lot, and so there's always a study for everything. And so that to me is exciting, kind of invigorating, kind of keeps, things fresh, so to say. Mundane, when you hear mundane, you think you don't want to do it. I know you're not talking about like note writing and that sort of thing, but I will say one thing, a little bit away from note writing, chart prep, okay? Chart preparation. When a patient comes in to a radiation oncologist, you don't say, hey, okay, what brings you in today? If you say that, the patient will look at you and say, well, you don't know, like a simple patient or simple treatment that you're planning to do for a patient has a very complicated history. If they already had a cancer diagnosis, already received prior treatments. So chronologically identifying all that information prior to seeing the patient, knowing everything about the patient before you go in to talk to the patient, that is the task. That's like, it can wear on you because, you haven't even seen the patient. You may spend an hour with the patient, but you spend 2 to 3 hours prepping. If you're calling a center that the patient had radiation to previously, or if they're on a clinical trial, or if you're looking for clinical trial eligibility, tumor board discussions. Getting all of that information together, it doesn't show up on the stat sheet, right? It just kind of it's in the background, so that, part of it, but it's necessary, right? You have to do it to make sure you have everything in order to give that patient the best decision, the best knowledge to make the decision for their care.
What's one thing that you would have wished you would have known before entering radiation oncology?
One thing I kind of heard about this when I came in, like most radiation oncology facilities are, part of larger hospitals and so forth too, but I didn't fully appreciate it. Radiation oncology, you're at the mercy of your referring providers, okay? You're the last echelon, okay? You can't just hang a shingle and open a practice, right? You can't just, family practice dentist. You can't do that in radiation oncology. We have $1 million machines, right? You got to have LINACs, you got to have vaults, you got to have certificate of needs, And typically because of that, hospitals bear the burden of setting everything up. And so therefore you come in almost like, just to manage that, that setting for you, right? And so the difficulty in trying to establish your own 20, 30 years ago was a little bit easier. Now the laws have changed, regulations have changed, things are more expensive. Hospitals are buying up smaller practices and so forth. So, and that's probably the same across a lot of specialties, but in radiation oncology particularly, your ability to see patients and to generate a livelihood for yourself is really predicated on the referrals from the referring providers in the community, and so that's something that I did not realize. That I just didn't appreciate that.
And what would you encourage a medical student to think about in earnest before committing to going into your specialty of radiation oncology?
I don't know. I think same holds true probably with any specialty, like I would just keep in mind that one truly doesn't know their specialty until after they're really in it, like I was really deep in the wanting to do radiation oncology as a third year medical student. And even then, I still had no idea, even when I was a resident, and now as an attending for 5 years, like you just keep learning. So I would just say that, a leap of faith is really probably the best, way to view almost any specialty, and just kind of like, you're not going to find the perfect one. It's not going to check every box. And that's what I would, just say. And I think not with just my specialty, but with any specialty that you're considering.
What do you think is the biggest challenge facing radiation oncology, and where do you predict the specialty to be within maybe 10 or 20 years from now?
Well, that's a big question. You're asking me. You should talk to some of my colleagues at the American College of Radiation Oncology. They'd love to give you a good soundbite of where they think it's going. I think some of the challenges that we see, is probably in the same vein for other specialties as well. I mean, quite honestly, our reimbursement is going down, and people don't like to talk about like reimbursement, but it's really important when you're in the community, because, in the community, you have less resources. And so in order to recruit more resources, you need money to recruit, but with reimbursement going down, you start losing resources. And what really hurts are the patients, right? The patients aren't able to get that immediate access to care, and so what I get worried about in my field is that, with the changes, you can graph it out. I mean, I think it's been like from the time I've gotten into residency and now, it's probably been like a 40%, 50% hit. Like it's just been downtrending. Right. And I get worried that I may not be able to hire any more partners. Right. I get worried that like my staff's going to start to feel the stress more and they burn out. Right. I get worried that, that the community's physicians are going to have a tougher time being able to, supply that demand for an aging population, and and the increased incidence of cancer, and so if I was a medical student or a resident coming in, I would think, well, wow, I know I could probably find a job, like I know there's, there, because there is a need, right? There is a need. But it's hard, I think medical students, we're really smart. We know how to look at all the data and kind of try to make the best decision. You want to be able to have a good job, have a good life, be able to have that time-life balance. And it's starting to strain. It's starting to, you can see that. And so I'm not saying that it's going to happen, but it's something that's in the back of my mind, something that I think about over the next 10 years. Like, man, what will it be like for community radiation oncologists and radiation oncologists in general, academics too, in 10 years from now, and that's what's in the back of my mind. And no one knows, that's all way above my pay grade, they say, like in the government and all that kind of stuff, and so, but those are things that I think about. I mean, that's a very high level discussion. I mean, something that you probably don't really think about as a medical student, honestly, but yeah.
Exactly. Yeah. Yeah. What resources would you recommend to students to learn more about the specialty of radiation oncology?
Honestly, I would just tell them to go shadow your local radiation oncologist. If you want to learn about radiation oncology, like especially if it's the WMed students that I listen to, you just send me an email, and call me, but anywhere you are who's listening to this, and it holds true of any specialty too, just go shadow someone and see what they do. For me, you probably, two specific days, like you come on 2 days and you get a good idea of what I do. You get a good sense of like, okay, these are the patients I see. This is my daily schedule. This is somewhat kind of my workflow, just kind of the nuts and bolts, just to kind of get an idea, and then, then you use that connection as a resource to continue to ask questions, I think in retrospect, you asked this too, in retrospect, I wish I could have talked to more practicing radiation oncologists. I talked to the residents. I wish I could have talked to more practicing radiation oncologists just to get a better understanding of what, the field actually is and that I'm getting into. And so I don't think there's any better resource than someone who's actually doing it. There isn't a book about radiation oncology that I know of. There are books about studies and that sort of thing too. But the crux and nuts and bolts of what we do, you got to come see it.
And unfortunately, students in the core curriculum, they just don't have that exposure to radiation oncology.
Mm-hmm.
It's not something, they're even aware of a specialty. So
right, yeah, no. So I mean, I didn't find out about it until I was like a third year medical student, and I thought it was radiology when I was signed up for it. I was like, what's this radiation oncology, and even if and that's because my program, my medical school at MUSC had a radiation oncology program, right? Like here, there's not a radiation oncology program, so you wouldn't even come across it, And so that's why I'm saying to like students that don't even have a radiation oncology program, just reach out to your local radiation oncologist. They would love to have. I mean, I don't want to speak for all radiation oncologists, but I can speak for myself. Love to say, come see what we do. Because no one knows. Like come see what we do. Yep. See the work that we put in. See what goes into each case that we treat. And the patients that are on treatment. It's I don't know. You'll learn a lot.
Tell us about how you decided your specialty was right for you. Can you tell me your story? What was that aha moment that it came to you that I want to become a radiation oncologist?
Full disclosure, when I was in medical school, every clinical rotation I went on, I thought I was going to do that. I was just so happy, start off on OB-GYN and then then peds. And then I think it was surgery next, and then neurology. It was neurology. And then I was like, okay, like maybe radiology. And again, like I was saying, like I thought it was more of a radiology rotation, because we're looking at MRIs and stuff in neurology. And I was like, oh, let me do this one. I was like, oh, that's not radiology, it's radiation oncology. But it was a shorter rotation. I was a third year. It was only 3 weeks, and I was like, I could do that for 3 weeks. But then the thing that stood out to me was like, it almost was like this, like, like selective, like it was like well, I don't know if you can do that rotation right now. It was in 2000 and probably 2012, 2013, 2014, radiation oncology was like a very competitive field to get into. Very, very competitive. It's a little different now, but still competitive, but just different altogether. You needed papers, you had to have the board scores and everything too. And so a little bit of a screening process went into me even like trying to do this rotation. So then I'm like, well, I got to see it now, like I'm going to sign up for it. I'm coming in there, right? And didn't know anything about radiation oncology. Day 2, it was a Wednesday. I think it was a Tuesday or Wednesday. They do chart rounds. Chart rounds is where you sit amongst other radiation oncologists within your practice and you review the plans and the treatments you have for each patient, kind of like peer review, so to say, right? And the residents that were there were being, questioned by the attendings on, well, how did you make this decision? Where did this come from? What are you talking about? Where did you read that somewhere? Where did you read it? What was it? What was the paper? All these stats and everything too. It was like I was in a courtroom, trying to justify why you were doing a certain, treatment for a patient. It was fascinating to me. I was just like, this is really neat, and so I talked to my friend, my college roommate, who's 3 years ahead of me now, because I took some time off between undergrad and medical school. And I said, hey, have you ever heard of the field radiation oncology? He was like, oh man, that field, I've heard good things about that field. You should he's like, how about this? He's like, if you think that there's a chance that you may really, really want to do this, like even if you don't want to do it, just go there the next day. Tell them this is your dream, that you just want to be there, you want to get involved and just soak it all up. I was like, really? Just, but I don't know if I want to do it. Doesn't matter. Just say you do. Just leap. Just go for it, right? So the next day, I'll never forget the look on everybody's faces. I was like, hey guys, I'm really liking this. I really want to get more involved. I think I may want to do radiation oncology. What can I do to help out? And they all took a kind of a look at me and they're like, well, we have these, patients that we're looking up, maybe you can help with this, or, hey, there's this, study that we've been trying to put together, there's some research you can do here. And I just kept saying, yes, 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 yes. Right. And so still didn't know I wanted to do radiation oncology, but I was on this path of learning about the field. Okay. And as you do that within radiation oncology and trying to go into the field, you need to do away rotations at the time. You had to do away rotations. And so they're like, well, look, if you really want to get your best chance to get into this specialty, you should do away rotations. And so I went to the University of Iowa Dr. Buwadi was the chair there, and I went to Oregon Health and Science University, and Dr. Charles Thomas was the chair there. And and these folks there, they just impressed upon me. It was just such a great experience, learning, seeing what they did, and it just kind of like, before I knew it, I loved it. Right? I was just, I can't see myself not doing this. Now I've been doing this, for the last year and a half, kind of pushing into it. Again, leap of faith. Had didn't know anything about radiation oncology. Did the away rotations, in Iowa, did it in Oregon, came back and applied, interviewed and got into my top choice. I wanted to go to Oregon after I had interviewed there, and actually I had done my away rotation. I really loved Portland. I really loved the attendings there, and they liked me too. So it really worked out, and the rest is, 4 years of residency plus an internship, and now 5 years in practice, right? And I still don't regret that. I don't regret doing what I did. I would have never known. Who knows? Maybe if I had put all of my eggs into like a pediatric basket or into like, ENT or ortho or M&R, maybe that would have been the same thing. But it just happened to be radiation oncology, and it spoke to me. And I don't know. It just came with me. I know, probably a long answer to your question, but that's really
that's great. No, that's wonderful. And you touch upon a couple of things. How important do you feel it is to do an away rotation in radiation oncology?
My biased opinion, I think, is not that if you don't do an away rotation, you can't match in the specialty, but it's very important for the student to see the program, to meet the attendings that would be shaping them and teaching them for 4 years, to see the area, to see if that's a place they really want to be. I mean, they're interviewing you. I mean, the 4 week, that 4 week, you don't realize it. Those 4 weeks is an interview. And if you like them and you do a great job and they see potential, it really helps augment your application for that particular program. So if there's a place you want to be, if there's like a location or region you want to be in, I would say find the programs there and do an away there for sure, And then if you really want to increase your chance of getting into the field, you don't have to do it. You don't have to do an away these days to get into a field of radiation oncology, but it can only help you. It won't hurt you because it is an interview. It's an opportunity for you to interview the program to see if that's good fit for you for 4 years, versus seeing it on a whim in 15 minutes here, 20 minutes there, with each person. So I would, my biased opinion is I would encourage it, at least one, at least one. I did too,
You did too. Would you encourage, and I know some students actually, for some specialties, they'll do a home rotation, and then they'll do an away rotation elective. This way they got some basis of understanding. Would you recommend that, or do you really feel like that's necessary?
No, I think, back in 2012, 13 era, I did my home rotation there at MUSC. And that kind of helped prepare me for when I went to Iowa, which also helped me prepare me when I went to Oregon. You just kind of build off that. So I would think that's very good. If you don't have a home rotation, again, I would recommend reaching out to a local radiation oncologist. And it could be similar to a home rotation where you understand kind of like, the pace in which we, discuss the literature and everything, and understanding. So you can add meaningful contribution to your team when you do the away rotation. No. 1 home, 2 away was the thing that we used to say in 2013. You wanted 3, but now, I mean, honestly, if you did 1 away rotation and do a really great job, that's great. It's good for the program. It's good for you. It's good for your visibility. You're able to get a letter from the people that spent so much time with you in the field that you want to go into. There's just so much value in it, and, we talk about value. We talk about our student loans, and you got to put up a little bit of money to find a place to stay. And is it worth the investment? For me back then, absolutely. But you don't have to do an away rotation, I don't think, right now. But if you could, and if you can, I think it would only help.
And then you kind of touched on another thing that, based on your experience, how important is research or scholarly productivity to successfully match in radiation oncology?
It's helpful, but not mandatory, like it was back in the day. I mean, I took an extra year, in medical school to help do some research projects. I had two, posters, that were accepted at a conference, and so I feel like that, I remember that, I feel like that kind of helped show like, hey, he's got the chops. He's willing to actually contribute to our field, right? And I felt like that was a really big sticking point, in 2013, 2014, that tended to elevate your application. Now I don't think it's quite necessary, but it doesn't hurt. It can only help.
So if you were a third-year medical student, undecided on specialty with limited time remaining before residency applications were to be submitted, what do you think would be the fastest, highest yield route to making a decision about the specialty of radiation oncology?
Highest yield again would be coming to rotate. Yeah, rotate with a local radiation oncologist. Go rotate in your local department, and time a week. When I was coming through as a medical student, I made a point to be at every chart rounds as a medical student, So when all the radiation oncologists got together, there I was sitting in the back of the room with a tie on, like eager and learning as much as I could, trying to soak up as much. Visibility is really important. And so, ideally, you want to be doing that before you get to this late stage, but you ask high yield way to like get as much information as possible. Again, I would just email your local radiation oncologist. If it's radiation oncology specifically, I would say email your local radiation oncologist and talk with them, and spend for me, it's 2 or 3 days with me, and then you get like a really good understanding if this is something you want to do. That would be the fastest, highest yield.
If you could go back and do it all again, what would you do differently, and what would you do the same, and why?
I can tell you what I do the same, because I'm very happy with where I am and what I've been able to accomplish and what I'm able to do. What I would do the same is, I would, continue to make sure that I was visible within the specialty that I wanted to go into. I kind of touched on that, sitting in on every chart rounds, asking how can I be more involved, figuring out a way, to be useful to the team, and being thoughtful and intentional about that. Those, attributes and those actions, I think, led me to find, research opportunities, which helped propel me into, potentially needing to do away rotations, right? Asking questions. The drive that I think of when I initially didn't know what I wanted to do, but that I put everything into this one field, that's what I would do over again, because I'm almost certain that if I didn't do it the way I did, I don't know if I'd be doing radiation oncology, and so that's what I would do the same. What I would do differently, hindsight's 2020, I try to buy a house in medical school, for the 4 years, I tried to, but it just wouldn't work out. It's going to, maybe start my backdoor Roth a lot sooner, seriously though. These are like little things that you don't think about, right? I had someone say that and I was just like, oh, wow. These are like small little nuggets that if you could do that, I was in Charleston, South Carolina. It's just a small little house, maybe $100K, $150K, to purchase. If you had that, you could kept it and rent it out to other students, right? You start that path of wealth, the wealth generation, I think in retrospect, realizing the cost of medical school, also realizing the lack of being able to pay off any meaningful interest on my loans as I was in residency, that's devastating, all medical students, you will realize this, that when you come out of medical school, and I got even a partial scholarship my last year, right? It's still, after you go out of medical school and then you're in residency, with your, 50, 60K salary, the interest that is being accrued on that is hard to touch while trying to make a living and learn your trade. So then it just balloons. And so by the time you got a residency, and radiation oncology is an internship plus 4, right? So that's 5 years. Yeah. Your loan amount is about 400, maybe, it could be high, I was like, I was high, and so it was high. I'm still knocking it off. And so just, I don't know, I guess more awareness to that. It's very easy to just be like, oh, it's going to be what it's going to be. I'm going to pay it off whenever. But, someone once said that, like, or so, I don't know where I heard this, like, you need to be able to generate income more than what you owe, right? And you have to see when you get out of medical school what you're going to owe and make sure that it makes sense, and no one told me that, but like, I feel very fortunate in the field that I chose and where I am now, that I'm like, I'm on the other side of it, but just having that awareness, I think just, is enlightening, for someone that's in medical school, not really even thinking about it. Right. So that's something I would, I would think more about it. I would think more about, I hate to say it, I would think more about the finances of it all, like, yeah, I really would. Golly, I would, like, I had a small apartment that I rented out, but then I was like, man, I'm paying this much for an apartment. That's more than what I could have paid for a mortgage if I could have had that house, right, for 4 years, And so it's just the number game, that I wish I was more intentional about that, because you come here to get training and to learn, to use tools so you can get your special training and residency. But in the process, you are taking on a lot of debt, and a lot of people, you just forget about it, So I would say, don't forget about it. If someone had looked me in the eye and said, by the way, you are investing in yourself, right? This is an investment in yourself. Think about a reverse mortgage or however you want to view it. It's an investment in yourself. That, I think, that conversation would have been super useful, to understand, like, no, I'm on my own. And then I'm taking out this investment so I can do a trade, right? But, you want to make sure that you don't end up, under it, right? And that's a conversation that that unfortunately I don't think a lot of medical students have. But I wish they could. And if they listen to this podcast, at least it puts a bug in their ear to be like, oh, wow, wait, what would it be? Like, hypothetically, 7 years from now, 3 more years of medical school, 4 years of residency at 7%. Like, oh, my goodness, right? Like, this is where you're going to be. So think about that, think about that, or add that into your calculus when you are thinking about, like, what you're looking at and so forth too, and what your goals are, family, career-wise, that sort of thing.
What is a career mistake that you've seen other physicians make?
One thing is that it's the settling, as a physician, we are taught to always be selfless. We're taught to always, try to just make do with what we have, and so forth too. But in doing so, that stresses us, mentally, physically, financially. And so I would strongly encourage any physician that's about to start a new job, start a new career, to make sure they rely on their resources, rely on their, their specialty groups, like the American College of Radiation Oncology, my group that I work with as well, to talk with other peers, to make sure that this is fair, this is equitable, so that you don't settle. And then 3 years down the road, when you thought, well, I just was trying to see what would happen and doesn't work out, you kind of know what you've already gotten yourself into, and that's the thing I've seen. It's the settling. Don't settle. You want to be intentional about what job you take, intentional about what contract you're going to sign. You don't want to just, leave it up to like, oh, well, we'll wait and see. And it's very easy to do that. Unbeknownst to all of us, when we're walking through the halls of as a medical student, then we go to residency, we're just dealing with it, right? We're just pushing on. We're just pushing on. But then when you get out of residency, it's still more to the same, And so you got to learn that, like, okay, where's that line going to be drawn? You want to make sure that, you're not settling, and getting what is worth to you.
What is something that you've seen another physician do well that has made you want to emulate it?
2 things, actually. And I just thought of the second one. One is mentorship. My mentors that I had, I talked about my chair when I was at OHSU, Charles Thomas. I talked about my vice chair, Jerry Jaboyne. And so I feel like now, even with any student that I see, any resident that I see, I kind of pour myself into them just so I can be as helpful as possible. What they did for me has allowed me to be successful. So I feel like I want to give that back as well to those that are coming up. I get excited when someone asks me a question. I'm like, oh, yeah. Let me tell you what I know. You don't have to, you don't have to listen to everything I say, but this is what I thought you asked. So here it comes, right? I really love to be in that situation, and I got that from them, and I just love that, that's something that I've seen and that I really want to emulate and that I try to emulate. The second thing is financial independence, financial literacy. Like I have mentors that are very even not even just as like physicians too, but they're folks that really look at just the basics of like having a Roth account, the basics of like what having a home can get you, for wealth generation, that sort of thing too. Having that financial literacy is very important because in medical school, we don't get that. I mean, we study, we study everything, cardiology, physiology, all, like neurology, everything. And, we study all these things, anatomy, but we don't study, financial literacy. And there are folks out there that see us and they know that and they try to take advantage. I've, seen, other docs kind of take me under their wings, kind of talk in my ear, about like, hey, look into this. This is a type of life insurance you want to get if you're going to get that life insurance. This is the type of disability insurance. Disability insurance are created equal. Not everyone knows that, right? They talk about the white coat investor, it's not my book, but the Bogglehead's Guide to Investing. Okay, yep. I don't know. You got this podcast going. I just want to say, like you call about the white coat investor. Yes, I like that. It's hard to live like a resident. It's really tough. But I would strongly recommend. It's always good to have different views, right? Yep. There's another book that I saw. It's called Die with Zero by Bill Perkins. Okay, and it's like almost like the antithesis of white coat investor. But I encourage folks to look at both. And kind of make sure that that delayed gratification is not too delayed, and so, yep. And having the best in your life. And so that book really challenges, that whole, resident, living like a resident, theory. But white coat investor, just that was really good for just basics on on financial literacy and so forth too, insurances and Roth accounts and investing and, that sort of thing. So that's really good,
Is there anything that you're struggling with or lamenting about your career today? And what are you doing to remedy it? And what would you encourage a medical student to do right now to help perhaps avoid this problem entirely later on?
I feel like, in my field now lately, some of my treatment, the plans that I draw up for my patients, I sit with the patient, I'm board certified, been practicing for 5 years. I come up with a plan and I say, I want to do that plan. And then the insurance company says, no, you shouldn't do that plan. You should do something else. And then that, that's becoming more frequent, and then what happens after that is I have to submit, articles and data justifying where my rationale is coming from. And then after that, they say, okay, right. But that's about an hour out of your day, maybe once a week. It's probably more for other practices than others. I'm in community practice, so we have less resources than bigger academic centers, but it's just, and we can't absorb the denials either. So you want to really put forth and make sure that we're doing right by everybody, yep. when we fight for it. And so that's become a very it hits. After a while, you're just because you did everything, you did all this, you have your data, but then it's well, no, show me a comparison, show me, what it would look like if you did it the way we want you to do it, right? And so you do that. So you're jumping through these extra hoops, and so that's starting to really, I really lament that. I just again. That comes up every now and then. Things you can do, things that if I was a student or even now, that we do is get involved in your colleges and donate to PACs, folks that are advocating for, your specialty to make sure that they keep the specialty intact so you can best effectively do your job, right? Those are things that wow, I didn't start thinking about that until year 3 or 4 outside of residency. There are groups out there that are working for you to make sure that they protect physician autonomy, and your ability to practice medicine as you see that is best, as your board certification says that you could, right? So, that's what's really important, and so that's what I would say.
What is one book, whether it's medical or non-medical, that you think every person pursuing a career in medicine should read?
who everyone in medicine should read. I don't know if everyone in medicine should read all the books that I've read. I talked about a few, the Boggerheads, Four Pillars of Investing, Dives. Oh, I forgot it. Yeah, this book. There are two, actually. I would say there are two books. There's one book
Okay.
that I found that I read when I was in medical school. You can't see it there. It's called Stumbling on Happiness. Yeah, by Daniel Gilbert. I thought that was a really I don't know. I thought that was a very good book for a medical student, because you're in reality, when you're like looking for what you think will make you happy, right, and your specialty, it's hard to know, right? And Stumbling on Happiness just kind of gives a perspective of kind of like how our mind works, and it's a scientific explanation of the limitations of the human imagination and how it steers us wrong in our search for happiness, and so it's unique. It's very unique. And I read it my second or third year in medical school. I don't even know how I had time to read this book, honestly. It's called Stumbling on Happiness, by Daniel Gilbert. And it was just unique. I just thought it was kind of nice, and it just kind of puts into perspective, like what is happiness, and we were searching for that even as a medical student, right? As we're like putting forth all those hours and so forth too, and we're trying to pick our specialty. I really enjoyed that. So that was a good book. So that book. And then the other book, maybe more so for when you're in residency and maybe your first year attending, it's called 4,000 Weeks, Time Management for Mortals. It's by Oliver Burkeman. And in this book, I just turned 40, so I have 2,000 weeks down. It really like puts into perspective like what matters, what's important to you, right? I had a mentor when I was shadowing a community practice in Portland, Oregon, asked me, they said, Simon, you got to decide for yourself what matters to you. She said, before you even write this book, you got to decide what matters to you. Do you care about like how many papers you write? Do you care about notoriety? Do you want to be the president or chairman of an institution? Or do you want to like be a good clinician and raise a happy family? What matters to you? You're going to have to answer that question. I didn't answer it then. I can answer it now, but they, like what matters to you. Right. And so this time management book kind of goes into the fact that like, look, you only got so much time, and we're built with minds that kind of like curse us to really dream big, and to try to think of all these different things when we don't really have that time to really to do that. It's very cruel, and so how do you make that adjustment? How do you, and how do you make that adjustment? How do you set those priorities? And I feel like for someone coming right out of residency or just start or in residency or, in practice, just starting a family, I think this book, I mean, it was really good. It came at the right time for me, and I would strongly encourage that book there too. You should put it on like a link so they could see it.
We're gonna I will be putting that in the show notes for all our listeners to go to and put that there. So wonderful. Well, is there anything that I haven't covered or you think that our listeners need to know about radiation oncology?
It's hard to cover all of radiation oncology in an hour. Like our field is so unique. There's so many pockets within radiation oncology. You can be a brachytherapist focusing on GI malignancies and GU malignancies, prostate cancer, cervical cancer. You could be a CNS lead, doing CNS oncology, treating with stereotactic radiosurgery. There's, so many different ways within so many pockets within the field that you could nestle in, like there are folks, even some, I have close friends that are in clinic maybe one day a week because they're in the lab the other 4 days, right? And they're really pushing that boundary of like, immunotherapy and within radiation, right? And the biomechanics of it and so forth too, bringing that work from the lab, to the community, that translational research. Like, I mean, it's just so, our field has so much variation in it. It's just so many different things you can do. I would say, I mean, this, and the folks that know me know I'm a cheerleader for my field, but if you can't decide what you want to do, just do radiation oncology. You'll find something in there that you like. No, I don't want to just say that. I will say this is really important. What we do is very special. Like I said, we see patients in their most vulnerable moments. There is a lot of talk, about like best quality of life, like end of life, right? Like a lot of times when we see patients, all options may have already failed. They've already failed systemic therapy. We're trying to get them as comfortable as possible so that, the remaining parts of their life can be as best as possible, right? And so that can take a toll. That can because you get to know these patients, right? You asked about the patient interaction earlier, so the patient, the family, like I typically send a card, after, so it's just like there's an emotional component, that is there in radiation oncology that I don't think is seen really in many other specialties that one should be aware of too, when considering the field, because you do have those very difficult conversations, but because you're seeing those patients in their most vulnerable state. One other thing, like not with just, radiation, but, for the medical students that are listening to, one piece of advice, that I would say, like, last words is you want to make sure you stay connected. You want to stay connected even with your peers, you want to stay connected and you want to have a community, because when you get into medical school, it gets really, the world can get really small. When you're in residency and you're grinding, the world can get really small. Even as and it keeps getting smaller, I think, the further you get out, right? And so, because you don't have the peers all around you. You want to keep your community wide and vast, and so, and the reason why is for that support, like even if you choose to not do the same specialty as one of your colleagues or your peers, it's good to have them, to have someone else around for that support. So I would say lean on your colleagues, lean on your peers, lift up, just the profession, together. And I think if you're able to do that, you will find that navigating the ups and downs of our profession will be much easier if you have that connection, that nucleus, around you.
It's truly been a pleasure talking to you, Dr. Brown. For the resources and other tidbits that were mentioned in this episode, you can find them in the show notes on the WMed website, wmed.edu/specialty spotlight. If you liked what you heard, please share this episode with your fellow medical students, especially if they're having some career anxiety. It is truly my hope that these conversations with physicians who've been there and done that will help you move forward with your own career choices. For any questions, or if you'd like to reach out to me for any reason, which I encourage you to do, you can do so by emailing me at biren.shah@wmed.edu. But until next time, take care.